Good evening, everybody, and welcome to the latest episode of iJournal Club, where we hope to get you familiar with some of the latest research and also get you some practice with research methodology so you can write your own clinical papers and so forth. So I'd like to introduce myself. I'm one of the young ophthalmology co-hosts. My name is Imran Yusuf. I'm an ophthalmologist and PhD student in Oxford. And I'd also like to introduce my young ophthalmology co-host, Artemis Matsou, who is a Cornell fellow currently at ESCRS in London.
Hello. And I would like to take this opportunity to welcome our expert faculty for tonight's episode. And they're both very well known, very experienced ophthalmologists, and they will be sharing their thoughts on our topic today. So Mr. Allan Barsam, who is a consultant ophthalmic surgeon at Luton and Dunstable Hospital, and also director of the Ophthalmic Consultants of London, and obviously has a vast experience in cataract, refractive, and corneal surgery. So welcome, Mr. Barsam.
Thank you. And also I'd like to introduce Mr. Bruce Allan, who I'm sure many of you are aware of, consultant ophthalmologist at a small hospital called Moorfields Eye Hospital down in London. And it's a pleasure to have such a distinguished panelist with us this evening. So thank you both very much for joining us. So this is the paper we're going to be discussing. And just to, before we get started, just a bit of housekeeping. Just so everyone's aware that the audience will be muted throughout the presentation, just to avoid background noise. But there is a Q&A button, so we strongly encourage any questions that you have, please ask through the Q&A, and we can direct those questions to our panelists. And a recording of today's program will be available on these various platforms, so you can refresh your knowledge at a later date. We're going to start with a poll. We'd like to get your views before we start on this subject matter. So I'll hand over to Artemis for the poll.
Thank you, Imran. So yes, we'll start with some questions for our audience, and you can vote actually even without having read the paper. So the first question is, do you perform toric or multifocal IOL implantation in your practice? Yes or no? And the time is on. Okay, so nearly 50-50 of you perform toric and multifocal IOLs. That's good. Okay, and next question. If you do you have predefined cutoffs for axial length, previous vitrectomy, or lens thickness for which premium IOLs are not recommended? Yes or no? The time is on again. Again, 50-50. The next one. Next question.
I can see it. I can see it.
Oh yeah, I can see it now. Sorry. So, do you think that capsular exercise, shape, and position is significant in the performance of premium IOLs? Yes, I perform manual capsular exit in these cases. 2, yes, I perform femtolaser assist in capsular exit in these cases. And 3, no, I don't think these factors are important. 50-50 again between manual and femtosecond assisted capsular exits. Okay, and we've got one more question. So IOL decentration versus tilt, which one do you think has a greater impact on reduction of visual acuity or increased aberrations? 1, decentration, and 2, tilt. 50-50 again.
This is perfect. We could
We've got a tie today.
Yeah. Fantastic. Okay, and that's very useful to know because clearly there's room for discussion here and room for manoeuvre. All right, so what I'm going to do is take you through the paper for those who haven't read it, and just to refresh memory for those who have. So this was published in JCRS very recently. So this was a paper looking at the characteristics and factors associated with intraocular lens tilt and decentration after cataract surgery. And you can see obviously the papers from the Far East. So what they essentially did is what they described as a cross-sectional study. And what they wanted to do was to essentially use a second-generation anterior segment OCT imaging device to assess, in a cohort of patients undergoing cataract surgery, what the degree of lens tilt and decentration was. You can see in the top left mini panel of this image, you can see this is how they assess decentration, where you can see the IOL appears to be slightly decentered, in this case 0.25 millimeters, and they also use this technique of measuring the angle between the optical axis and the corneal vertex axis to determine what the IOL tilt was. So essentially, that's the technique they wanted to apply to this patient cohort following cataract surgery. Just to give you an idea about the patients involved, there were 196 patients. The mean age of the patients was 66.38, so slightly younger, for example, than that in the National Ophthalmology Database, which is a big study done in the UK. And we'll talk about generalizability of the study as well. They record what portion have diabetes and hypertension. 13 of the 196 had a previous pars plana vitrectomy. They give some scores in terms of whether nuclear or cortical opacity was present. You have some pre-operative biometric indices there of anterior chamber depth, lens thickness, and axial length, of which the mean axial length was 24.5 millimeters. Most of the cataracts they reported being age-related, and I think what they mean by complicated is secondary cataract formation. And there are two sort of indices at the bottom which reflect the intraoperative occurrences within the group. So they mention the IOL type implanted. You can see mostly hydrophobic lenses, but there were 46 hydrophilic. They also mention in the paper it's a combination of one-piece and three-piece lenses, although they didn't analyze those separately because there were only a small number of three-piece lenses used. And they also give a description of the amount of capsular excess IOL overlap, where you can see in 70 cases out of the 196, there was a 360-degree overlap. In 92, there was between 180 and 360-degree capsular excess overlap of the IOL, and 34, there was less than 180 degrees. So those were some of the characteristics of the group. So in terms of what do they find about the IOL tilt and IOL decentration, and of course, this has taken these measurements are 3 months after cataract surgery. Initially, what they wanted to show was that there was no difference between the measurements in the midriatic and non-midriatic states. So they actually took non-midriatic measurements in the end after proving this statistically. And you can see in the first column for IOL tilt, the number of patients who had less than 5 degrees of IOL tilt, there were 107. There were 67 who had between 5 and 7 degrees, and 22 with more than 7 degrees. And in terms of IOL decentration, you can see that 100 patients had an IOL tilt of less than 0.2 millimeters. There were 75 who had decentration between 0.2 and 0.4, and 21 had decentration greater than 0.4 millimeters. That's very, in a snapshot, what they found. They qualify those figures a little bit further in this figure, where they show you the histogram plot, so you can see the distribution of the data. And what they also show in the right-hand side of the panel is the direction of that tilt or decentration. And you can see that for the IOL tilt, there seemed to be a pattern whereby this was likely to occur in the inferior temporal quadrant of the right eye and the inferior temporal quadrant of the left eye. However, with decentration, there was no obvious pattern as to which direction this occurred in. And this table is probably the most important in the paper, presenting the results. So on the left, you have the IOL tilt results, where they performed a univariate and then a multivariate analysis. And we've obviously been through these types of analyses on previous papers we've looked at that. So as regards to IOL tilt, they found that on a univariate analysis, so identifying the effect of a single variable, female gender, previous pars plana vitrectomy, and a negative correlation. You can see the minus sign here. So IOL tilt was negatively associated with axial length. In other words, a shorter axial length was associated with tilt. But when they did a multivariate analysis, the only two factors which were significant were previous pars plana vitrectomy and a short axial length. And for IOL decentration, and they did the same analyses on this particular outcome measure, and you can see that on the univariate analysis, lens thickness and axial length were statistically significant on the univariate analysis, as was the overlap of the capsular axis and IOL. And on the multivariate analysis, the most significant factor was axial length, but also capsular axis IOL overlap was also significant on the multivariate, as was lens thickness. And you can see the p-value given there. So that really is the main table of results. They also usefully provide these scatter plots. You can see each individual data point for the 196 patients, where they plot in the first graph the axial length from 22 to 32, and they give the amount of tilt, and they obviously provide this fitted line showing what they feel is a negative correlation between the two. And similarly, they also provide axial length in order to determine what the effect of that is on decentration. And here you can see the fitted values indicate a slight positive correlation. They don't give R-squared values or p-values for the fit. And so what they wanted to look at lastly was what was the effect on this on visual acuity. So they looked at different variables like age, gender, diabetes, hypertension, IOL tilt, and decentration. And on the univariate analysis, there were two factors that appear to be significant, so the presence of diabetes and age, and there's a positive correlation with age. And these factors also seem to be significant on the multivariate analysis. And so it was important also to realize, however, that patients who had a diagnosed eye disease or previous surgery that might affect acuity, such as high myopia, fundus diseases, glaucoma, previous plasma vitrectomy were excluded from the analysis. So what they wanted to do was to work out whether IOL tilt and decentration were significant in terms of visual acuity on multivariate analysis. And you can see that here they weren't. So it's useful to know, to see whether you feel that the findings of the paper justify what they feel as if they added. So what they feel as if they've added is that a history of past planar vitrectomy and short axial length were associated with a greater degree of IOL tilt. And they also felt they showed that a longer axial length, large capsular axis overlap with the IOL, and lens thickness, an over large capsular axis, and lens thickness were associated or correlated, with a larger decentration. So that's really what the paper showed. So now what we're going to do is pose some questions to our expert faculty who are now very familiar with the figures and so on. So Artemis, shall I hand over to you to start?
Thank you, Imran. So obviously we have a list of questions for our faculty, and we would like to invite our audience to do the same. So you can participate as well with the Q&A button on your screen. We have two brilliant speakers, and please take advantage of this opportunity. I will start with a question for Mr. Barsam. So in terms of measuring the intraocular lens tilt and decentration, I think in the literature, there's no unique definition of the reference axis against which tilt is measured, and different reference axes have been used in different studies, for example, pupillary axis, corneal vertex, and visual axis. In this study, it's the corneal topographic axis that the authors use via this equipment, the second generation tear segment OCT. Do you think that's a more accurate way of measuring? Is that what would you prefer as well in your practice? Mr. Barsam? I think you need to unmute.
There we are. Thanks. Yeah, I think the thing about that measurement is that it's the measurement that's most accessible to the most number of people, because most people have at least a placido-based topographer that allows them to make a measure of where the corneal vertex is, which closely approximates to the line of sight. So it's the one that you would consider to be the most significant. So I think it's fine to use that as a measurement. I think that the reality of where the visual axis actually lies in relation to the corneal vertex, when you really get into the nitty-gritty of the optics, is more complicated. But in terms of a kind of practical, everyday reference point that people can use, it's fine.
Good. Okay. And Mr. Allan, would you agree with this one? Would you suggest something different?
Well, truthfully, you asked me about my own practice. I can't get terribly excited about either tilt or decentration or indicators preoperatively for it, because the effect on vision is so small here, and small degrees of tilt and decentration are quite well tolerated. I should say, I'm coming to this paper not terribly well prepared, but I thought the presentation was great, by the way, Imran, really lovely. Very clear. But I mean, what I'm seeing here is fairly intuitive. The patients who are most likely to have problems with decentration are the patients who are most likely to have a problem with a slightly elastic zondule, in other words, the very long axial lengths. the people who've got a poor rexus, that's another group. And well, that's just down to surgical technique. And as for tilt in shorter eyes, I've never really given it a great deal of thought. I don't know about you, Allon, but clinically, it's not a big problem. It really isn't. You know, it's with accommodative lenses, that was where it was a big issue. We saw tilt develop over time with capsule contraction. The missing piece, just, you know, eyeballing this data here, is preoperative assessment of the anatomy. We have no real indicator of the lens, the natural lens position in the eye or tilt, whether that's different in people with shorter axial lengths. So I understand what the investigators have done here. It's a nice, accessible look at data. I'm not sure how useful the conclusions are. I'm probably going to get an opportunity later, but I'm worried that I forget what I'm going to say, because as I say, I only scanned this paper in the 5 minutes before I came on, and a couple of things stood out to me right away. Am I allowed to go on and on? Allon, I hope you shut me up if I'm going on for ages. But looking at the stats here, okay, they picked out a few things they thought might be influential and measurements they did actually have access to. And they looked at those in univariate analysis. Okay, so no argument with that. That's a common starting point for, you know, trying to pick out what is having an influence on your dependent variable, your factor of interest, you know, the factor you're looking at. But then they went on just to run a multivariate analysis without doing anything to exclude factors that were clearly not relevant in their univariate analysis. The normal approach would be to set a slightly kind of higher threshold or a wider open door than you would normally have for statistical significance. Say p equals 0.15 is a common choice. And you pick out the factors that you see in your univariate analysis that have at least some indication of statistical relevance. And then you move those forward into a multivariate model. They seem to have just taken all the factors, ignored what they found in the univariate analysis, and run a multivariate model. And that's problematic. You know, you can have problems with your conclusions if you base them on that. And so I didn't like that when I saw it. And the other thing that jumped out at me straight away when I looked at the scatter plots, which is what you should always do if you're looking at regression analysis. And if you look at the long axial length versus decentration, are you able to pull that up, Yusuf, for us on the screen? Is that possible while I talk?
Sure, I'll do that.
Yeah, there we go. So I can't point for you, but if you look at decentration and you look at the extreme end of the axial length there over at 32, you see some higher decentrations in that group. Well, you kind of expect that. These are the patients with the really elastic zonules. But in drawing regression lines, there's something called the pull factor, which if you have some measurements at the extreme end that are all in one place, it can give you an unfair idea of the, you can't assume the regression is linear, and it can skew the regression line. And here, if you exclude those measurements up above, you know, up at 32 there, those four there, and you look at the others, it's not nearly so clear that there's a relationship between tilt and decentration and axial length, except at the extreme end, which is kind of clinically where you'd be starting to be very conservative about your lens choice. So, and, you know, Allon may have a take on this, but, you know, one little useful takeaway for, you know, routine cataract practice is that in patients who have a longer axial length than you know, 28, the kind of biometric cutoff for when you're really starting to think about these things, you might want to put in a large capsule tension ring routinely just to give the zonule a bit of extra help there coming down the line. I've certainly had cases with an extreme myopia of anterior capsule contraction syndrome later down the track. It's one of the risk factors for that. And so, what the paper's showing here is at one level quite intuitive. The reviewers, I think, have maybe let a few things through that I would have passed back to and asked them to look again. But the thing that is rather failing to excite me here is I'm not really seeing anything that jumps out at me and saying, oh my goodness, I should look carefully at this factor preoperatively. Don't know, perhaps I'm being a bit harsh.
Right, well, that was one of our questions actually, whether you feel that this paper would have changed your practice and whether you will start managing these patients differently, especially if you're considering putting a premium intraocular lens, a toric or a multifocal lens in these patients. Would that change your
practice? Well, look, so I can tell you now that I've gone right down the range in terms of shorter axial lengths and multifocal lenses, and without too much of a problem. The big debate there is whether a large angle kappa is a problem for a multifocal lens, and you can form different. It might be a subject for another journal club, but it's just it's a difficult area. The evidence seems to be that it doesn't make too much difference, but it's certainly something I worry about. Similarly, pupil size, if someone's got a very small pupil, even with a pupil independent multifocal lens, a diffracted multifocal, they generally have a central zone that's less pupil dependent. And so I worry about small pupils and large angle kappas, but it's not very evidence-based. And at the other end of the scale, for the high myopes, I tend not to use multifocal lenses, because you're likely to run into slightly more zonular problems. And so, where do I cut off? Well, notionally, people who are kind of down at the sort of greater than 28 axial length, I at least think about it for sure. And you can get, you've got to keep it real in everyday practice. And these patients are more likely to run into other pathology because of their high myopia. And so, they're going to get a great result with monofocal lenses and a bit of micro monovision. So, my strong steer for anybody who doesn't have a formed view of their own is that, independent of anything this paper is saying, I would agree that at the higher end, you want to think about using a premium lens. But at the lower end, tilt, wow, I've never got too excited by it, truthfully. But I could be wrong, as I say, it's very important to keep an open mind on these things, because you've got to keep on learning, and that's all we're here for. Allon, what do you feel about that? It's a kind of broad brush. Where is your practice at in terms of where you draw the lines with multifocal lenses? You got any tips for the people tuning in here?
Yeah. Well, I agree with all of what you said. I don't. If I was reviewing this paper, I would have definitely rejected it or asked for an extensive revision. One of the things that I find immensely frustrating about papers in clinical journals, because this is actually a clinical journal it's published in, not a scientific journal, is the obsession with surrogate endpoints. And when I say surrogate endpoints, they're things that you measure but are actually of no meaningful implication in terms of a patient's visual function necessarily. They do in their introduction say, we know that tilt and decentration is associated with aberrations, but actually, if that was what we were interested in, then they should have been measuring aberrations, or they should have at least been measuring visual acuity or refractive data, or all of the things that normally correspond with the patient's visual function, all of which they've totally omitted from their paper. There's a really great quote that I would advise anyone listening to bear in mind when you do anything within your clinical or research practice. I think about it often in terms of clinical governance and many of the things that we do in day-to-day to try and process and guide us and keep patients and our practice safe, which is that if you do not measure what you don't value what you measure what you value. And there's so much measurement going on without people thinking about whether it's really meaningful or not. And I think that when anyone comes with any question of, is this of interest, the first thing they should say is, what does this actually mean to our patients if it's something clinical. So that's my main thought on the paper. And as you say, even if they were going to present surrogate endpoints, why not show us some of the preoperative measurements? Because actually, when you're confronted with a patient and you're thinking, should I put a lens in? As you're, I will get on to answer your question about where I draw the line, but you're thinking, should I put a multifocal into this patient? Should I use a toric? Should I use some other kind of lens? Well, actually, what were the angle kappa measurements in these patients? Because we know that in hypermetropic patients, which tend to be patients with shorter axial length, they tend to have a larger angle kappa anyway. So their finding of decentration in low axial length patients is really just showing us information that we already know, and that they could have discerned, preoperatively without having to use their kind of OCT scanning device in order to generate all of those measurements. They also don't give information about the lenses, and there's this assumption that every single lens behaves the same, i.e. all multifocals are the same, all hydrophobics are the same, all three pieces are the same, all one piece are the same. Actually, the extent to which individual haptics and optics correlate and compress or don't compress in a variety of different anatomies within the eyes will be different. And so it would have been nice at least to have information on what actual lenses they were using. In terms of the sensitivity to decentration, the asphericity of the individual lens that they're talking about is relevant. So for example, most Technis J&J lenses have a spherical aberration of minus 0.27 microns. The Alcon lenses are about minus 0.2 microns. It bothers me to even have to think about this stuff, so I prefer to use lenses that don't have any aberrations built into them if possible. But the reality is that lenses that are more aspheric will be more sensitive to decentration, even if they're monofocal. So irrespective of whether it's multifocal or toric, and they're saying, oh, you need to be a bit more careful in a toric lens because of decentration. Actually, there's no reason that a toric monofocal would be any more problematic if decentered than an aspheric monofocal. And if any of you see patients with aspheric monofocals that are significantly decentered, they can end up with huge refractive error because the lenses are not powered the same in the center as they are even in the mid-periphery. I think actually with a toric lens, you might worry more about tilt, because the problem with tilt is not just high order aberration problems such as coma, but also you can induce astigmatism. So you're trying to correct astigmatism with one lens and you have promised that to the patient. And then if there's tilt, potentially they could end up with astigmatism. And in the rare cases where you see patients where you've used a toric lens, you refract them afterwards, there is still refractive error and the toric alignment is exactly as planned and as you would have otherwise intended, i.e. there is no explanation for why this patient still has astigmatism. You wonder if potentially lens tilt is the problem there. But as Bruce says, it's so rare and it's just not a huge issue. And even in the unlikely event that one of these refractive patients does end up with refractive surprise or residual refractive error, it's very easy to do laser vision correction in order to correct that. So I think the kind of real world take home, how do I change my practice on account of this paper, is absent, possibly even totally missing. But I think it does generate an interesting discussion about when do we need to be careful with respect to premium lenses. And as Bruce says, again, I do look at angle kappa preoperatively, but it doesn't totally exclude any of my patients. It just shifts my threshold a little bit. And I would say the same thing for high axial length. So again, low axial length, I don't worry about too much. High axial length, I will increase my threshold for using a multifocal, but it doesn't mean that I will totally take that option off the table. It depends on other factors in terms of what the patient's expectations are, et cetera, et cetera. And the same goes for angle kappa. But papers that look at angle kappa and multifocal lenses generally look at higher values than have been presented in this paper. So it's really figures in excess of 0.5 or 0.6 millimeters. And if you look at the kind of central distance orientated portion of most trifocal lenses now, it's about 1.5 millimeters. So they are actually very forgiving. And I don't think that these factors there are many other factors for which you shouldn't be using premium lenses, trifocal lenses or toric lenses, but worrying about axial length or previous past planar vitrectomy, those aren't the main issues in my opinion. Past planar vitrectomy might be an issue because you'd be worried about macular function, but not because you worry about lens tilt or decentration, in my opinion.
Absolutely, yeah. And obviously, you say, both of you said that the authors failed to detect any difference in the corrected distance visual acuity, and it would be much more interesting to see the effect of all that to aberrations. And what kind of aberration would you expect to see in tilt and decentration, significant tilt and decentration? And do you measure that in your patients routinely, preoperatively, postoperatively, especially for premium IOLs?
Well, yeah, so we measure it. We would measure it in any patient that's complaining of a quality of vision issue postoperatively.
Mm-hmm.
We don't measure it routinely preoperatively because often these patients have lens opacities or other problems that would essentially interfere with a overall ocular wavefront or internal aberration measurement. But we do diffractions in all patients that you can extrapolate a rough idea of how aberrated you would expect their visual system to be on account of the cornea alone, if you like. You'd expect all aberrations in a patient that's got significant decentration or tilt. But again, whether they're significant or not, who knows? Because actually, higher order aberrations are also, in my opinion, a surrogate endpoint. You might argue that the point spread function, which is for those, for any of the kind of trainees in the audience that don't know a lot about higher order aberrations, most aberrometers will generate something called a point spread function, which is essentially replicating what it envisages a point source of light would look like to that individual patient based on the high order aberrations that have been detected. So the point spread function, I think, is probably not surrogate. That's probably what you'd expect from an aberrated visual system. That would be interesting to look at, but you can't quantify a point spread function. It's qualitative. It's just an image that you look at, and it's useful clinically because you can show it to a patient and ask them if that's what they see when they look at a point source of light, if they're complaining of quality of vision issues, especially in mesopic conditions. Aberrometry is complex. It's dependent on pupil size and the pupil size that you're measuring, and the pupil size that the patient might have at the time where they may or may not be complaining of quality of vision issues. So I think what would be much more meaningful, and what's missing from like almost every single refractive paper you ever read, are validated quality of vision questionnaires. That's really what you want to know. Can the patient see? Do they function? What's their reading speed like? Et cetera, et cetera. Even visual acuity, is a little bit not real world. You're looking at a black letter on a white screen in a well-illuminated room. It doesn't tell you how a patient feels when they're driving in the rain at night. So what you really want to know from all lens patients, and that's what they'll tell you in clinic, by the way. So it's not me just being fussy about it. If patients complain to you, they'll always tell you where their problem is and where it's happening. And it's not often in a well-lit room in a very controlled environment. So, quality of vision questionnaires are gold dust. They take time to do. It needs to be done prospectively. It's very burdensome from a research perspective, but it's what we all want to see. And in bigger numbers than are presented in this paper as well, because 196 eyes of a relatively large demography is still quite a small sample size.
Absolutely, thank you. And
so I can just speak to that briefly, if I may, Artemis, just on quality of vision questions. It's quite reassuring, really. It's we've done a few trials of multifocal lenses at Moorfields, and the standout, well, one of the things we looked at was decentration in relation to visual quality using a questionnaire called the QOV, which is not perfect, but possibly the best visual quality questionnaire we've got. And we didn't see any relationship between lens measured decentration and quality of vision scores, or indeed visual acuity scores. So it does seem that most modern multifocals, short of an obvious anatomical problem with the lens, a bit of decentration, it doesn't look great on the slit lamp, doesn't make you feel good when you're looking at it, but it doesn't seem to be correlate very well with symptoms. But Alan's right, you've got to listen to your patients, and that's a very important thing. But I think you can be reassured that modern multifocal lenses perform pretty well, and they're quite tolerant to the kind of degrees of decentration that the authors are seeing in this paper.
Great, thank you. And Imran, I think you've got some questions for our panel.
Yeah, I do. Just to remind the audience, do ask questions on the Q&A and we'll happily redirect those to our experts. I suppose just to sort of summarize where we've got to so far in the discussion, and just to have a question that leads from that. So what you both are probably saying, if I understand you correctly, is that if this study was repeated, even with a multifocal or toric IOL, premium IOLs, you still, with the same outcome measures they used here, you still wouldn't be that interested because you would expect that there wouldn't be any clinically significant effects.
So, Imran, we've got a nice thing on the Q&A here it's from Ruth Lapid Gorchak. Thank you, Ruth. Just saying, look, if there's clinically significant tilt or decentration, it's obvious in the slit lamp. You don't need to do the measurements. I think that's about right, actually, in terms of things that would make you really worry. This paper is not going to make me start routinely looking at tilt and measuring tilt and decentration post-operatively in patients who are happy. That's for sure.
There's also, they look at lens thickness too, or at least lens thickness is something they feel as though has some significance. Do you use that parameter? Does that have any significance for you at all beyond the impact on biometric calculations?
Well, I'm just looking at the table now, and lens thickness in the multivariate comes out. Well, it's hard to make sense of the stats because of that comment I made earlier about the way they did their multivariate modeling, but it's 0.029, a very small effect. I'm not convinced that it's independent of axial length, really, but I could be wrong.
Yeah, okay. And I got one more question about the generalizability of data, because of course there are studies from different parts of the world, and I suppose your predominantly European audience listening to this will probably think, well, even if this is true, is it really relevant to a European audience? And just to qualify that, for example, in the National Ophthalmology Database, I alluded to the axial length seen in this paper at 24.5, whereas in the National Ophthalmology Database, the mean axial length, and that was 23.5, so obviously a millimeter shorter on average. And also the mean age of the cohort was 66 years, and again, compared to a UK large study where the median age of surgery is 77 years. So what are your feelings about generalizability in sort of a European population for this type of study?
Well, Allon's still on mute, so I'll take that one. I think that it's very important to look at the population you're studying, and there are many examples of that. And so if there's an important finding in one population group, the thing to do is to look in another. And I'll give you a really good example of that jumped out at us at Moorfields just recently, and that's ICL implantation. There's sizing, as you may know, is one of the key issues for ICL implantation, and one of the weak areas that that we still need to work on. And we've got some very nice info from Japan, from Nakamura there, who's derived a really nice upgrade on the sizing algorithm based on swept source OCT. It's the MS39, and he's got a regression formula derived in a Japanese population. So the point you're making there is highly relevant. Before we adopt that wholesale, we really need to do the stats ourselves on a European population, because we may find variations in the formula. And so I think the point you're making is very important, that when you're considering a study, you also have to consider the study population and how it compares with the patients that you're working with yourself before you directly import the findings.
Okay, thank you. Allan, do you have anything further to add to that? What's your view?
Yeah, I mean, I don't. I think it's if the findings were more relevant, then you would be more concerned about making sure that the population is synonymous with the one that you're more interested in. But actually, I would argue that in a kind of, if you're worried about premium lenses, because their main conclusion or take-home message as well, these are the groups you should be concerned about with multifocal or toric patients, then actually you would expect that cohort of patients in general to be younger, because the older patients are a bit less concerned about spectacle independence in general. I mean, that's obviously a generalization. There are many more elderly patients who do want to get rid of their glasses, but I find it to be more a phenomenon of a younger patient, maybe because it's more part of an active lifestyle, and maybe that will change over the next 10 or 20 years. People are getting increasingly more youthful. But I think that if the findings were relevant, I would still feel it was relevant in that you can still extrapolate and find the information there. But yes, obviously, ideally, you want to see it in populations that you're more interested in. But I don't think that the differences are as large in different study populations when you're looking at this is quite a, as one of the audience said, you can see it at the slit lamp, you're talking about quite gross anatomy here in terms of how lenses move, how they tilt, whether it would be different in someone that's 60 as opposed to 70 or 65 to 75, or different ethnicity. I'm not entirely convinced I would expect a huge difference in those populations for this particular factor. I think for other things, maybe that wouldn't be the case. They've excluded patients with pseudoexfoliation syndrome. So if you were in a Scandinavian population, you'd end up excluding a huge population of your patients from the study. Maybe they should have included those patients because they are actually patients of interest. I think one of the things that's worth noting is in patients specifically with thicker lenses, when you come to operate on them, you can often see folds, and I call it kind of like a floppy bag, but you see folds in the actual capsular bag as you're operating, especially with more modern microscopes where the red reflex is exceptional. You can see subtle abnormalities or anomalies with respect to the capsule contour. I tend to put capsular rings into those patients because I just don't like the idea of putting this relatively flat lens into a really floppy bag because you don't quite know what's going to happen. And if you end up with a fold or ridge at one of the compression zones or where the optic haptic junction is or at the edge of the haptic, I do worry a little bit about decentration in those patients. In toric patients that have axial lengths of more than 26 millimeters, and it's a bit arbitrary, only because I've had a couple that have spun on bigger ones, I again tend to put a capsular tension ring in because I feel like it compresses the equator of the capsule. It causes more anteroposterior compression in the region of the haptic, and I know my opinion probably makes a toric lens less likely to be rotationally unstable, but it's not because I worry so much about decentration or tilt in those cases.
Okay, lovely. And just one question following on from what you said. In patients who are highly myopic, who do you suspect have a more floppy capsular bag, I think you mentioned that you use a capsular tension ring and you'd put a one-piece lens in, perhaps on average. Is there a particular indication for using a three-piece lens with a larger haptic diameter in high myopes? Perhaps I could ask both of you that.
Yeah, I mean, that's an interesting question. And it's actually one thing that this paper got me thinking about, which is that we're putting lenses in that have a haptic length, essentially a haptic length that is the same in patients that have got very different anatomy. Bruce was talking about the ICL, and admittedly that sits in the sulcus, and sizing is much more of a potential problem or danger, if you like, because you don't want them to excessively vault or vault insufficiently. But even in the bag, you might argue that if you're putting it into a 13 millimeter eye, you might like to have a 13 millimeter or 13.5 millimeter lens. And in fact, in the very abnormal eyes, like patients that have got megalocornea or arrested congenital glaucoma or ophthalmos or any of these cases, you do really worry about what lenses you put in the bag because you really feel like it will move a lot. And likewise, in a hyperopic patient, as this study has kind of shown, maybe there's more compression going on and you get tilt for that reason, and you should be potentially using a smaller lens. So as we go to kind of customizing lenses more, maybe people would look at that. But I think that you'd have to have information and data to drive that. So you'd have to show that it was the lens position and maybe lens tilt and maybe lens decentration that was contributing to the quality of vision or refractive error. And then you could look potentially at a more customized lens size. And it wouldn't be the optic diameter, it would be the overall haptic length, in my opinion, of the lens that you'd look at. Because the only thing that we customize actually is the power, if you think about it. The lenses are all otherwise identical.
Bruce, do you want to come in on this? What's your view? Oh, you're on you're on mute, I think, Bruce.
Sorry, yes. You caught me daydreaming there. But the really, I would come back on this in a slightly different way, which is because the dinner gong is about to go. We're running out of time, I see. So I just wanted to ask you guys, really, because this is quite relevant to you and Artemis at the stage in your career you're at, and you've got a really exciting period ahead of you, I think, in terms of some of the answers here. You've asked Allon and I on as experts here, and well, that's great, to have some opinion. And I think it is helpful in terms of broad practice points. But there are some some things that we're going to find out in the future from the evidence base that are going to change what we do. And the question is, are these kind of studies really going to do it, or are we going to look at it in a different way? And so I'm going to ask you, do you think that in your careers that we will arrive at the happy state where all of our medical data will be in some well-organized data warehouse, that anyone with an interest in finding the real answer to a question will be able to interrogate? Do you see that coming, or do you think that's fairyland?
I suppose if I might answer that first, Artemis, then I'll hand it happily over to you. But I suppose it really depends, I think, on how well, I think our skills, not just ours, but of other specialists into the data analysis, obviously becoming more important in daily life and in all aspects. But I suppose in order to garner, that's the right question, to get the right answer, obviously you need very good data sets. And I think it's where Medisoft, perhaps in the UK, has given us answers to questions that we wouldn't have had if we didn't have that infrastructure of data capture. So perhaps if we were able to do that, to capture those, all of this data, I mean, all the biometric indices, and anything else we can possibly feed in, then perhaps the answer is attainable. I did mention that in an essay to ESCRS. They didn't like it because I was sort of taking the power away from the surgeon towards these sort of systems where perhaps AI or something else might tell us these answers. But I do think if the infrastructure is there, then we should be able to find even small trends if we capture the data on a wide enough from a wide enough group of patients. Artemis, over to you. What do you think?
I think I agree with you, because the way we record data is very important, and obviously, on a national level or even international level, we may be able to have registries in future, so we can collect more data from many countries, and maybe then we can be able to detect a difference, perhaps. But obviously, we need to be able to do this critical appraisal of every paper that we read and the published literature, because that's still a qualification that every doctor, I think, should have. A lot of papers are out there. We just need to be able to select which one we feel, and based on the evidence, we believe that it can make a difference to our practice. Yeah, so it's a difficult question, really. But
we've never been asked a question before, so.
All right, putting you guys on the spot, really, and so. But I mean, just to make a general point, to get you and the other guys tuning in a little bit excited about this. What they've done here, the investigators, is they've picked out a few factors that they think are relevant before they start. And the exciting thing about machine learning approaches, which become possible when you have large data registries, is that you don't have to know in advance what it is that is the relevant factor, because you've got algorithms that can look at the data across the piece, all the noughts and ones, and light up an area that you never knew was relevant before. And that's what's so exciting, I think, about. I'm kind of jealous of you guys coming into it at a stage when medicine is going to be, you're going to have these great tools at your disposal, and it's going to change everything. I think it really will.
As long as you're not disposed in the process, then that's very welcome.
Yeah, no, don't worry. You won't be redundant. I mean, it's just, medicine is no fun when you don't know what you're doing. And so the more we know what we're doing, then, the better we'll sleep at nights, and the more happy patients we'll see.
Absolutely, yeah. So I think we've come to dinner time now. So I think perhaps Artemis, now, since we've got no questions from the audience, perhaps you might run the poll.
Yeah, of course. So I think we had a very informative discussion, and we have a few more questions for our audience. Some of them are similar to the ones in the start. So first question is, do you think that axial length, lens thickness, and previous vitrectomy should be used to help determine the suitability for premium IOLs after all we discussed? Yeah. So majority now feel yes. I think it was 50-50 initially, so now 87% feel yes. See? Next question. So do you think that capsular exercise, shape, and position is significant in the performance of premium IOLs? Yes or no? Again, that was similar to the initial question. And that's again, yes, the majority, 96%. I think, again, we were 50-50 when we started. And our last question. Do you think we should have a lower threshold to offer toric or multifocal IOLs to our patients? First option, yes. I think that would increase patient satisfaction after cataract surgery, especially in the era of refractive cataract surgery. Or no, it may increase medical legal claims. Which one do you think? So most of you feel that we should offer it more. Okay, that's very interesting. Thank you. So back to you, Imran.
Yeah, lovely. Thank you. That was very interesting. Right, here we go. So lastly, just remains for me to, on behalf of Artemis as well, to thank our two panelists. It's been a really interesting discussion, and also the discussion was reflected back at us, which was also something new. But I'd like to thank all of you for joining us, and I hope you've all learned something from the discussion this evening. It's been an interesting one. And I suppose what I'd like to do for all of you is just to whet your appetite for the next episode of Journal Club. So this will be on Wednesday, the 2nd of December, 2020. And we'll be discussing this very interesting paper of the 5-year follow-up of the first 11 patients undergoing injection of cultured endothelial cells for corneal endothelial failure. So what we hope will be a very interesting paper to review there. So once again, I'd just like to thank both of our panelists tonight for joining us this evening. And I hope you've learned something and enjoyed this episode. And we'll see you next time.
Thank you very much for having me, both of you, and good luck with these sessions. I think they're great. And Allon, nice to see you.
Nice to see you too. Thanks very much for having me as well.